be able to introduce Dr. Haley Miles McLean. Um, I will read her formal introduction, but Haley is a fellow at the VISN 5, VA VISN 5 Myrick. And so I get to work with her a lot. And so I think she's great, developing a really important line of research. And I'm thrilled that she's here today. But now let me give you the formal intro. So Dr. Miles McLean received her degree in Human Services Psychology with a focus in clinical and community psychology at the University of Maryland, Baltimore County. She has clinical and research expertise in intimate partner violence, trauma, and women's mental health. She's currently a VA Advanced Fellow in Mental Illness Research and Treatment at the VISN 5 Mental Illness Research, Education, and Clinical Center. She's also a visiting fellow here at the University of Maryland, Baltimore, in the School of Medicine. In her role as a fellow, she participates in ongoing federally funded research that is focused on improving the well-being of veterans with diverse identities. She also serves as an interventionist on a VA-funded study testing cognitive behavioral therapy for chronic pain among veterans with serious mental illness. Dr. Miles McLean's research focuses on promoting the functioning and well-being of women veterans with mental health conditions. She is particularly interested in addressing needs related to aging, reproductive health, and gender-based stress and trauma. She's currently working on a pilot study exploring the experiences of women veterans with mental health conditions during the menopause transition to inform ongoing research on this important intersection. Her work hopes to inform further research on behavioral health interventions that address the critical connection between women's mental health and age-related physical health conditions in order to promote functioning among aging women veterans. Dr. Miles McLean, thank you for being here. I'm going to hand it over to you.
Thank you. Can everybody see my slides? Okay, perfect.
Yes.
Great. Well, thank you so much, everyone, for being here today. And it's exciting to hear everyone's background. Sounds like we've got some folks sort of in school kind of developing their specific interests, some research, individuals already engaged in research. That's really exciting, especially in terms of thinking about fostering collaborations and other areas for growth. So as I go through this talk, if you have questions, you can put them in the chat or let me know, but I know also we have some time at the end set aside for questions too. So just to give you a little kind of roadmap about what we're going to be talking about today, I'm going to give some general kind of background on women veteran population, how that's changing in recent years and how it's projected to change over time. Talking a little bit about the biopsychosocial model generally and how I think it's really useful in particular when we think about age-related needs of women veterans. A little discussion about clinical considerations, like how these might be integrated into clinical practice, as well as how you might consider those things if you were developing research interventions for this population. And then I'll discuss menopause a little bit as sort of a indicator condition, if you will, or a nice way of kind of thinking about how the biopsychosocial model applies to a specific experience of women. Just another note in terms of language for the talk, I am going to use the term women most of the time because of the fact that that is where most of the research is done on cisgender women, veterans in particular. But obviously there are individuals who have diverse experiences who identify as women, including trans women who may not have some of the biological experiences or risk factors that I'll be talking about that are consistent with individuals assigned female at birth. So just a language note there about the terminology I'll be using. Okay, so talking a little bit about women veterans broadly and what the population looks like. So women veterans are the largest growing population of veterans. So it's estimated by 2025 that there'll be about 12% of the veteran population. And actually that the rate of women veterans in Maryland is growing particularly quickly. So this is a great talk to be able to deliver to the UMB group, given the fact that there are estimates that women veterans in this state in particular is going to be growing. So it'll be something relevant for research and clinical practice. Over half of women veterans are aged 45 or older. So the population of women veterans is older and aging. And so that is part of where my interests come in around thinking about how aging intersects with women veteran experiences. And given that a lot of them are seeking VA care in particular at higher levels, and I do a lot of work in clinical care within the VA specifically. In addition, about half of women veterans in VA care have mental health conditions, which is higher than the rate of veterans that are men, higher than the rate of general mental health conditions among civilian women as well, with major depressive disorder and PTSD being two of the top 5 service-connected conditions. And just for reference, if folks are unfamiliar with that term, service-connected conditions has to do with basically whether or not it's thought that some of these conditions are related to military service, and whether or not some of those services can also be covered as part of people's care at VA. So it basically is describing like how representative are certain conditions and how common are they within the women veteran population. And then in addition to those mental health conditions, the remaining top service-connected conditions for women veterans are migraine, back pain, and uterus and or ovary removal. So as you can see, kind of looking at this information, there are these chronic health conditions that are experienced by women veterans, both mental health and physical health, that are really like highly represented within the population. And there is also some research to suggest that all of these conditions have overlap with aging, with challenges as individuals age, and we'll talk a little bit more about that as we go along. So one model that I think is, like I mentioned before, really helpful in particular when we think about women veterans is the biopsychosocial model, which probably many of you are familiar with since it is used obviously in clinical practice and research more generally. But it's just a nice way of sort of highlighting the fact that all of these different aspects that one person might be experiencing intersect and impact one another to result in different types of health outcomes or functional outcomes. And that when we're thinking about a highly clinically complex population, that it's really useful to have a strong conceptualization in my experience to really try to think about, okay, like how are all of these factors coming together to influence the individual's lived experience and their healthcare needs. So this model actually has been, there's an adapted version of the biopsychosocial model that is age-related, and it was adapted then by Reber and Lacroix to look at women veterans in particular and their age-related needs because of the unique factors in this population. And I'm going to go into specifics in the next couple of slides about what like different factors, risk factors come up for folks as they age. But really this does a nice job, as you can see in this model, highlighting how there are these different intersections for women veterans around aging, how the body changes as we age, how social factors and experiences can change as we age, how gender also can influence aging, both from a biological perspective for individuals that are assigned female at birth, in terms of changes to hormone functioning, things like menopause, the potential for reproductive cancers of ovaries, cervix, things like that. And then also veteran status, both thinking about, apologies, I went forward, both thinking about risk factors associated with veteran status. So things like exposures to deployment and combat related stressors, as well as things like toxic exposures that can occur through being in the military, but also protective factors like access to VA care. Obviously, not everyone has access to this kind of integrated healthcare system in the general population, and that can be a benefit potentially for individuals if they are able to access VA care and the kind of integrated health services that we offer. So thinking a little bit more about what are some of these particular experiences or health factors, I'm going to go through some different considerations of health experiences that are overrepresented in women veteran populations, and or our experiences that can really influence the aging process. And as we kind of go along, I would just encourage you to kind of to notice how some of these things that I've divided into sort of biological, psychological, or social really do overlap with one another, like that Venn diagram in the model shows. So in terms of thinking about like risk factors or things that can exacerbate biological aging or health risks, especially as individuals age. Women veterans can have some unique exposures to toxic chemicals through military service, through deployments, things like that, that is not represented within the general population. It's part of why you've seen the PACT Act was just passed in Congress, really recognizing some of those risk factors that veterans can have related to things like exposure to burn pits. And that obviously can influence health and the aging process. Smoking is also a very serious problem for women veterans. They have higher rates of smoking than the general population of women, as well as higher rates of smoking than men veterans on average. And so when we think about obviously that conferring risk for all kinds of health outcomes, that there is some concerns there, and also a lot of overlap between smoking and psychological factors like mental illness. We know smoking is more common in folks with major mental illness. In addition, women veterans have experiences of sedentariness, and particularly like having a lot of decline in physical functioning and activity as they age, relative to when they were younger and maybe in the military and more physically active. Metabolic risk syndrome is also overrepresented in populations of women veterans. So things like having high blood sugar, excess body fat, around the waist in particular. And interesting to note here, when we think again about sort of how these things intersect with one another, that individuals with who take certain psychiatric medications, who have often like serious or major mental illnesses, they can also experience increased metabolic risk factors through that. So when we're thinking about how these things come together. And then also women veterans have higher rates of hypertension. And in particular, there's also some really interesting research showing really high rates of hypertension during pregnancy for women veterans. It's much higher than the general population. And hypertension during pregnancy can actually confer risk as you age for cardiovascular disease and other poor health outcomes. So when we think here, right, like a lot of things that are going to be potentially impacting these age-related illnesses or chronic illnesses, including cardiovascular disease, stroke, diabetes, and cardiovascular disease is much higher in women veterans. And the women veterans also have very high rates of chronic pain conditions like migraine and back pain, which is one of those top-rated service-connected conditions. So in terms of psychological risk factors, I did put in here our psychological experiences, trauma, in particular types of trauma that are overrepresented in women veteran populations. But I just want to note that this does overlap a lot with social, right? We think about these Venn diagrams of the biopsychosocial model, there is that overlap. But women veterans experience gender-based discrimination, just kind of generally similar to women who are not veterans. We know that's related to poor mental health outcomes and impacts people's functioning. Women veterans also experience military-specific harassment, both during military service as well as, unfortunately, there's a growing body of literature documenting experiences of harassment at VA specifically. So when they're there getting care services, still experiencing harassment. There's a lot of efforts right now doing research, including at our MIRAC, to work on addressing that concern. Women veterans also have higher rates of exposure to gender-based traumas like childhood sexual abuse, even before they're in the military, intimate partner violence, and military sexual trauma, which is experiences of like sexual assault and harassment in the military specifically. So not only are they exposed to sort of gender stressors that all women unfortunately are exposed to, but they also have these higher rates and these unique experiences associated with veteran status. Women veterans, like we were talking about before, have high rates of major mental illness, things like MDD, PTSD, and that impacts their functioning and wellness. And also women veterans have high rates of suicide, higher than the general population of women, though some of the recent interventions do seem to be helping bring that rate down, but it's a very intense area of focus within VA research right now. In terms of thinking about social considerations, especially related to age, women veterans often have high rates of caregiving burdens, both to their children as well as to like parents or other dependents in their lives. And that can kind of be, we think about like how this picture couples together, that women veterans have higher rates of divorce than the general population. And then of course, when we think about age, women live longer on average. There's sort of these compounding effects that can happen that impact social support And their women veterans also have higher rates of homelessness, difficulties in meeting their basic needs some of the time. And this is not women veterans specific, but that one thing that can happen during aging that can really impact women are changes to bodily appearances. And there are a lot of cultural pressures around how women's bodies look, how they look as they age, that can really impact people's wellness. And there is some like kind of qualitative, descriptive data to suggest there may be some particular challenges for women veterans with that in terms of changes from baseline functioning. So thinking a little bit about how this might come into play with clinical care, something that's a big initiative within VA and very interesting to me is patient-centered care. So we're thinking about how would we tailor treatment to consider these biopsychosocial factors. So in terms of care, we think about personalized, how would we look at all these different risk factors that an individual is coming in with, these different protective factors, and how do we then integrate that with their care plan? So we're making sure we're addressing their needs in treatment. In addition, we want to think about being proactive. So focusing not just on problem areas, but also areas where we could grow and strengthen the individual's resilience. That might be through like holistic care, like helping people with mindfulness, yoga, nutrition, things like that. And then we want care to be patient driven. So thinking about, okay, if we've got a person coming in with a lot of different concerns or a lot of different needs, how do we talk through with them what their preferences are for care, and then use that to help build engagement in treatment. Okay, so talking a little bit about menopause. So like I said, this is just sort of when we think about where all these things can intersect, as menopause is a major transition in people's lives, something that all women will experience, all women, veterans as well. And that can impact them for years. That menopause symptoms can extend beyond the transition to menopause. And about 1/3 of people's lives are spent in menopause for women. So there can be very significant impacts on functioning as a result of that. And these challenges can really be exacerbated from the data. It seems like for women veterans, they have worse quality of life associated with menopause symptoms, suicide associated with menopausal stress, and also changes to their chronic pain. And that women with major mental illness, in particular, this data is not yet on women veterans, there's limited research in that setting, but can experience increased symptoms, changes to treatment efficacy, and associations with traumatic stress, that can exacerbate the experience of menopause symptoms. So something I'm really interested in is expanding this area around looking at women veterans with major mental illness as a group with particular health risks and disparities that need some attention. One intervention potentially that could be used is called cognitive behavioral therapy for menopause, which is a CBT treatment that focuses on a variety of different domains, like helping folks develop new coping skills and strategies to manage menopause symptoms, and has data to show that it helps with hot flash concerns, improving quality of life, addressing sexual functioning, sleep, and mood. But again, limited data for women with mental illness. And so, like I was mentioning, I'm really interested in exploring these intersections, thinking about if we know women veterans with mental illness have these challenges with functioning, they have a lot of comorbid physical health concerns. Those physical health concerns impact their mental health, vice versa. We know that aging for women with mental illness is really challenging a lot of the time, that there's higher mortality and difficult health-related outcomes, trauma and PTSD being linked to challenges with aging. That I really want to hopefully bring some of this literature together using that biopsychosocial model and thinking about how do these unique challenges come together for women veterans with major mental illness, their health concerns, stress and trauma, military experiences, and what sort of patient-centered interventions can be developed to help them. Thank you very much.